Thanks for joining us this morning. I'm sure more people get on as we get moving along here, but my name is Dr. Jeffrey Stimac. I'm a fellowship trained hip and knee replacement surgeon. Did my fellowship up at the Hospital for Special Surgery, and then I practiced in Louisville, Kentucky for a little over 12 years. And then I've been down here at HSS at NCH for almost a year now. And we're going to just talk about hip arthritis and then total hip replacement. Just have a brief presentation, and then we'll have time for questions at the end. So first of all, just talking about the hip joint itself. So the hip joint is overall a relatively simple joint. It's a ball and socket joint. The ball is the top of the thigh bone or the femur, and then the hip socket is, in the medical terms, is referred to as the acetabulum, which is sort of a disc-shaped structure within the pelvis itself. So if you look at a healthy hip joint, the ball as well as the socket are covered in something known as articular cartilage. If you look at the end of a chicken bone, for example, that's articular cartilage. So it's a shiny, smooth surface, and that cartilage fills the space between the ball and the socket, and it allows the ball to move freely without friction within the joint. So what is hip arthritis? With hip arthritis, the cartilage in the joint breaks down or is damaged, and that occurs both on the femoral head side as well as on the hip socket side. And what happens is initially you'll get some thinning of the cartilage, and then over time it'll continue to thin all the way down until bone gets exposed. And that leads to rough and uneven surfaces that will grind on each other, which leads to pain. It will lead to clicking and popping and stiffness. So the reason hip arthritis becomes more and more painful over time is when the bone gets exposed, there's nerve endings in the bone. And those nerve endings normally are covered by the joint cartilage. When the joint cartilage wears down, those nerve endings get exposed, and then they're not used to that, and that becomes painful. Other aspects that you see in hip arthritis, in addition to the loss of cartilage, is bone spurs, which are bony overgrowths. Those occur on the socket side as well as on the ball side or the femoral head side. So if you get bone spurs on those two sides, those bone spurs will actually hit up against each other, and that can be painful, and it can also lead to stiffness. So here's x-rays. The one on the left-hand side is a normal hip joint. So you can see there's plenty of space between the ball and the socket. That space is filled with the articular cartilage or the joint cartilage. And then the other thing you don't see are bone spurs. And then if you look at the image on the right-hand side, that's an arthritic hip. So you can see at the upper part of the joint, all of the joint space has been worn down, and now the bone of the hip socket and the bone of the ball are touching each other. Other things you'll notice is there are, see if I can use my pointer here. Looks like maybe I sort of can. There is bone spurs right here off the ball. So it's just a bony overgrowth. And when you move your hip, that bony overgrowth will hit up on your hip socket up here, and that'll cause pain and also limit your motion. There's also a bone spur down here. The medical term for bone spurs is osteophytes. The other thing that you'll notice is in the ball of the hip joint, the bone right in this area is more white than, oops, skipped ahead, sorry, than the bone in the ball here. And so that area is an area of hardened bone that happens when the bone gets exposed, and that is called sclerosis. And the final x-ray finding that you will see on an arthritic hip are bone spurs, which bone cysts. So there's a bone cyst right here in the hip socket, and those just form as the normal or a part of arthritis. So what are the normal signs and symptoms of hip arthritis? Obviously, everybody knows pain. Normally with hip arthritis, the pain is going to be in the groin area. I would say that's probably 90% of how hip arthritis presents. You can see it in the buttock and sometimes on the side of the hip. Traditionally, buttock pain is more commonly either coming from the gluteal muscles or from the spine. If you ever have pain that radiates down your leg, that's coming from the spine. Sometimes hip arthritis can present more with thigh pain, and that's because the nerve that supplies the hip joint also supplies the sensation of the thigh down to about the level of the knee. And then pain on the outside or the lateral side of the hip, that usually is coming more from hip bursitis, but once again, not in all cases. So once again, the pain's typically going to be in the groin area. Activities that often will cause the pain: walking, stairs, putting shoes and socks on, getting in and out of the car, getting up from a seated position, going up and down, getting up from going up and down stairs, and then from a sports perspective, the turning motion of golf certainly can irritate the hip joint. Running, pickleball, all those different types of activities can certainly cause pain. Patients often will have stiffness and loss of motion as the arthritis progresses, and often will walk with a limp. So as far as treating hip arthritis, always want to start with conservative treatment. Surgery is typically only recommended when the conservative treatment fails. So one thing that we can do to help improve the symptoms is activity modification. So avoiding activities that cause pain. So a lot of those would be more of your high impact activities: running, jumping, pickleball, tennis, where you're kind of cutting back and forth. Those can all irritate the hip joint. And you want to focus on more low impact activities. So biking, swimming, weightlifting are all good exercises in patients who have arthritic hips. So strength training is important for all of us as we age. It helps with the symptoms of hip arthritis. It increases the strength of the muscles around the hip joint, which can help stabilize the joint, and it'll help decrease the forces across the joint, and that can help reduce pain. It can help our ability to perform activities of daily living, can improve our range of motion, our balance, and probably most importantly, as we age, it helps improve our bone health and strength, which can help prevent fractures. And then obviously we all know the benefits in regards to our mood and our well-being that comes with exercise and strength training. Weight loss is another thing that is important in patients who have arthritic joints. And when you lose weight, it decreases the forces across your hip joint. That can help reduce pain. So when we walk, each step we take, we are putting actually 2 times our body weight on the foot that is on the ground. And then when we go up and down stairs, it's 4 times the body weight. So when you are, losing weight, you might think 10 pounds is not really that much, but really when it's 2 times that when you're walking, and 4 times that when you're going up and down stairs. So even modest weight loss can actually help decrease the pain from arthritic hips and knees. The other benefit of losing weight is if you ever do elect to have surgery, it'll help reduce your risk profile. So obesity is one of the more common risk factors for wound complications and infections. And infections are certainly a big concern as a surgeon. You can also adjust your diet to help reduce inflammation. So inflammation helps drive arthritic pain. And so by changing what we eat, we can decrease inflammation. Our diets here, particularly in the United States, are packed with processed foods, and these processed foods are inflammatory to our bodies. So by getting rid of processed foods and switching to more single ingredient foods, we can help reduce inflammation. People may hear of like a Mediterranean diet or a paleo diet as diets that can help people who have inflammatory conditions like rheumatoid arthritis or psoriatic arthritis, but they can also help in osteoarthritis as well. So what we want to do is we want to eat more lean meats, fish, fruits and vegetables, and then healthy fats. And we want to avoid our processed snack foods like, chips, crackers, cookies, etc., fast food, fried food, sugary desserts, and then also alcohol is pretty inflammatory to our body as well. Physical therapy is really important for arthritis. It can help improve strength and range of motion as well as stability. If it's done before surgery, it certainly can help make the recovery from surgery easier as well. Non-steroidal anti-inflammatories, these are the most common medication as orthopedic surgeons that we prescribe in treating arthritic joints. So those are things like Aleve and ibuprofen, which are often over-the-counter medicines, and then prescription-based medicines like meloxicam and Celebrex. And those will help decrease inflammation and thereby decreasing pain. Important thing to note about anti-inflammatory medicines is they do have side effects. They can affect your stomach, causing ulcers. They can cause kidney issues. And then obviously if you're on blood thinners, they can thin your blood even further. So you really want to make sure you check with your primary care physician if you're going to try to take these medications long term to make sure they're safe for you to take. Supplements can also be helpful for arthritic joints. So there are natural anti-inflammatories that we can use. Fish oil, CBD oil, turmeric, and ginger. Those are all natural anti-inflammatories. Glucosamine and chondroitin sulfate is, I tell patients, sort of like a vitamin for joints. It's a natural component of our joint cartilage. And so we're sort of supplementing that natural component, and that may or may not help reduce pain and function. Other ones are collagen, vitamin D, and vitamin C. In my experience with supplements, some people get very good benefits from them and other patients may not see those benefits. So it's really going to be a trial and error kind of situation for each patient. Injections are also something that we utilize in the treatment of arthritis. Now, I will say in the hip joint, injections don't tend to work as well as they do in other joints like the knee. One type of injection that we commonly do are steroid injections. Steroids help decrease inflammation and therefore will help decrease pain. The injections can last weeks to months, depending on how arthritic the joint is. If a patient's joint is more arthritic, it's less likely that the injection is going to work, or if it does work, it's more likely to last a less amount of time. Steroid injections are overall pretty well tolerated by most patients. Key thing to note about any type of injection is once you get that injection, as soon as you can have surgery is 90 days. And that's because the risk of infection if you have surgery before 90 days is higher. Another type of injection, which is often done for arthritis, is something called PRP, or platelet-rich plasma. So that's where we actually draw blood from your veins, and that gets spun down in a special centrifuge, and it concentrates the platelets. They get those platelets out, and then they'll inject those into the joint, and then those platelets actually cause the release of growth factors into the joint, which will decrease inflammation. And it may also possibly activate and cause the proliferation or growth of cartilage cells within the joint itself. The key thing about PRP injections is these are usually not covered by insurance, and the cost of those can vary between probably $750 per injection to upwards of $1,500 per injection. Another type of injection is hyaluronic acid injections. In general, hyaluronic acid injections are not commonly used in the hip because they are typically not covered by insurance. Very commonly used in the knee joint. Some people refer to these as viscosupplementation injections or gel injections. So hyaluronic acid is actually a naturally occurring component of our synovial fluid. So the synovium is the lining of every joint, and that lining produces fluid, which helps lubricate our joints. So the hyaluronic acid could potentially lubricate your joint, cushion your joint, and they can also help decrease pain. But once again, they are not typically covered for the hip joint. Finally, total hip replacement. Obviously, this is reserved for patients typically who have pain that affects activities of daily living, walking, rest, sleep pain. If it prevents you from doing things you like doing, like golf and pickleball, and it's patients who have failed conservative treatment. So it's what we do in a total hip replacement is we are replacing the ball and the socket, versus a partial hip replacement. You are only replacing on the femur side or the ball side, and partial hip replacements are typically reserved for people who fall and break their hip. The goal of the hip replacement mostly is to decrease pain, but it certainly can improve motion and certainly will improve function. Hip replacement is considered probably the best surgery in all of orthopedics for improving quality of life, and possibly even the best surgery in all of medicine for improving quality of life. It really will allow most patients to get back to activities they enjoy, such as walking, hiking, golf, pickleball, etc. There are not a lot of restrictions after you recover from a hip replacement surgery. I typically do tell patients that running is not a great form of exercise just because of the pounding is a lot of wear and tear on the artificial parts. But otherwise, most people can get back to doing pretty much what they want. And hip replacement should last hopefully 25 to 30 years if it's done well. So for most patients who are getting hip replacements, they're often in their 60s and 70s. sometimes younger, but so it should hopefully last most patients their entire life unless they have it done at an early age. And that's usually for a different reason other than hip arthritis. The surgery typically takes about 45 to 60 minutes, depending on the surgeon. My surgeries usually take me somewhere between 30 to 45 minutes. Back when I first started into practice, most patients stayed in the hospital a couple of days. Patients often went to rehab for 7 to 10 days after surgery. Now hip replacement surgery is typically considered an outpatient procedure where you get to go home the same day. Some patients still do stay 1 or 2 nights. Usually that's for social reasons, if they live alone or if they have a significant number of medical comorbidities where it's safer to monitor them within the hospital. After surgery, you will usually have a walking aid. Typically, most patients will use a walker, sometimes for a couple of days, maybe up to a week or so. And then after that, on a cane for a few weeks. I would say most patients are off of any walking aids between 2 to 4 weeks. Physical therapy is very helpful after hip replacement surgery. So often you'll get home physical therapy for the first 2 weeks, which is usually done with a home health agency, or sometimes there are self-guided physical therapy programs that people can follow. And then some patients will do outpatient physical therapy after they complete the home physical therapy. These are all very famous, well-known people who have gone on to have hip replacements. Shaquille O'Neal's had both of his hips replaced. All those golfers down in the bottom pictures, they all still actively golf. So you can certainly get back to doing the things that you want to do after a hip replacement. As far as the recovery, usually 4 to 6 weeks out from surgery, patients are doing pretty good for day-to-day activities. By 3 months, the majority of patients are back doing all the activities they like to do. Some people can recover a little faster. Some people recover a little slower. In my experience, patients who are more active before surgery are going to recover a little bit faster versus patients who maybe tend to be a little bit older, or patients who are maybe already on a walker. Their recovery is going to take a little bit longer. Full recovery can take upwards of 9 to 12 months in some patients. I would say most patients, it's probably in the 6 to 8 month range. As far as returning to sports that everybody likes down here in Naples, golf, I usually let people start putting and chipping around the green, 2 to 3 weeks after surgery. Wedges around the green, 100 yards and in about 4 weeks out from surgery. Short irons around 6 weeks out, and then probably back playing normal golf within 8 to 10 weeks, depending upon the person. Pickleball, I usually let people start playing around 8 weeks out from surgery if they're recovering well. So there's different approaches that can be utilized for hip replacement surgery. When I got into practice, the posterior approach was the most common way hip replacements were done. At that point, I would say around 80 to 85% of hip replacements were done through a posterior approach, and maybe around 10% were done through the anterior approach, and then the rest were done through lateral and other approaches. Over the last 15 years, the anterior approach has really gained popularity. And now about 50% of U.S. surgeons who have been cued report they at least do some anterior approach hip replacements. So the posterior approach hip replacement is an incision sort of on the buttock area or the side of the hip. And you have to split the gluteal muscle, which is obviously a pretty big muscle. With the anterior approach, the incision is more on the front of your hip, and instead of splitting a big muscle, you actually go between 2 muscles. So what are the benefits of the anterior approach? Like I said, you're not splitting a muscle, you're going between muscles. As a result, there's less muscle damage, and that's been proven with research. That less muscle damage leads to less pain, so people are able to get off of walking aids quicker. They're able to go up and down stairs reciprocally faster, and often get back to activities a little bit quicker. If you look at the research comparing anterior approach and posterior approach hip replacements, usually they equalize within about 2 to 3 months, and so even the posterior approach long-term is still a really excellent surgery. I always tell patients you are better off choosing the surgeon and letting them do the approach they're best at than you are necessarily choosing the approach. I think you're better off having a posterior approach hip replacement with someone who does 200, 300, 400 hip replacements than you are having an anterior approach done by someone who only does 25 hip replacements a year. There is a decreased risk of dislocation, which is when the ball comes out of the hip socket. With the anterior approach, the risk of dislocation long-term is around 0.5%. With the posterior approach, it's somewhere around 1 to 2% historically. The other benefit of the anterior approach is there's no hip precautions after surgery. With the posterior approach, historically, people couldn't cross their legs for a couple of months, and you couldn't flex your hip beyond 90 degrees for a couple of months. Even with modern day techniques, a lot of posterior approach surgeons no longer have hip precautions, but that is one other potential benefit of the anterior approach. Anytime you have surgery, it's very important to understand that there are risks involved with the surgery. As a surgeon, the thing I worry about the most would be a surgical site infection. That risk historically is around 1%. I will say the anterior approach has a little bit higher risk of wound complications and infection than the posterior approach. And prevention really is key. And the prevention is actually not only the surgeon and the healthcare system, but the patient is equally as important in helping to prevent infection. There are things that can increase your risk of infection. So diabetes, obesity, smoking, autoimmune disorders, drinking, those can all increase your risk. So the more you can modify those factors, the less of the chance you'll have of getting an infection after surgery. If you do get an infection after a hip replacement surgery, it does usually require more surgery and often antibiotics for upwards of 6 weeks. Another thing that can happen after surgery are things called DVTs, deep venous thrombosis, or blood clots in your legs. Once again here, prevention is key. So after surgery, you will typically be prescribed a blood thinner somewhere between 4 to 6 weeks to help prevent blood clots. Anytime you have a hip replacement done, your legs can end up different lengths from each other. As surgeons, we try to get your leg lengths as close as we can possibly get them, with the goal of getting them within a couple of millimeters. There are different ways of doing that. With the anterior approach, I use X-ray in the operating room, and my X-ray machine actually hooks up to a second computer, which is called OrthoGrid AI, which is an artificial intelligence system that interprets the X-ray image and can help guide me in determining my leg lengths. Other people might use robotics to help with leg lengths. So there are various ways that we can help control that. Dislocation is another risk. That risk is historically around 1%. If you get a dislocation, unfortunately, it can occur multiple times and can require further surgery. Nerve injuries can occur. Large nerve injuries are very uncommon. So that would be things like your femoral nerve or your sciatic nerve. With the anterior approach, there is something called the lateral femorocutaneous nerve, which is a sensory nerve on the front of the hip. And it's actually not uncommon for that to get damaged. Around 25% of patients will end up having a little decreased in sensation just to the outside of their incision from the surgery. Anesthesia complications can occur depending on your surgeon. Anesthesia can be a general anesthetic, or for my patients, I use a spinal anesthetic. Spinal anesthesia helps with pain control. It helps decrease the risk of anesthesia side effects and actually decreases bleeding during surgery. And then finally, you can have fractures during surgery. Pretty uncommon to have those, but they do occur. And if they are missed during surgery, that can result in further surgery being required. So how do you know if you're ready to have surgery? So it's the pain that is consistent with hip joint pathology. So once again, that's going to be pain typically in the groin area. Usually patients are going to have chronic pain, so pain for at least 3 months, and often patients will have pain for several years before they end up having surgery. The pain should affect your quality of life, whether that's your walking, activities of daily living, your ability to sleep, or if it's things like sports such as pickleball or golf that you enjoy doing. And then it's always important to have failed conservative treatment, so your NSAIDs, your physical therapy injections, etc. Now, I will say you don't have to have failed all the conservative treatments. Most patients will do activity modifications, maybe physical therapy or a home exercise program, and typically NSAIDs. Not all patients end up doing injections. So this is the contact information for my office, as well as 2 different websites you can go to get to our group's webpage. Just a little bit about us if you're not familiar with us. So HSS at NCH is a collaboration between the Hospital for Special Surgery, which is based in New York, and then NCH, which is Naples Comprehensive Healthcare here in Naples. So we have a good-sized building here in Naples. It houses pretty much everything that we need. So we have an outpatient clinic where we see our patients. We service, the services we provide are joint replacement, sports medicine, hand, foot and ankle. We have non-operative spine, non-operative sports, as well as trauma. We have outpatient physical therapy within our building. We have inpatient operating rooms. We have an inpatient hospital floor with 15 beds. So you have surgery right here in our building and stay within our building until you go home. We have inpatient physical therapy for the patients that stay in the hospital. We do also have an ambulatory surgery center, which is where all of our outpatient surgeries are done. And then we also have imaging, including X-ray, CT scan, MRI, as well as ultrasound. So we really are a one-stop shop here. And that's it, if anybody has any questions.
What can I do before surgery to prepare and improve my recovery?
So staying active, I think, is the most important thing that you can do. If you have a hip that hurts, obviously it's hard to be active, but it is really important. The stronger you can be, the easier it's going to be to recover after surgery. I think controlling your medical comorbidities. So if you have diabetes, getting that well controlled. If you're a smoker, if you can stop smoking for a few weeks before surgery, that can certainly help. I think increasing your protein intake, before surgery, it can help with your healing after surgery. And then you can certainly, as you're getting really close to a surgery date, there's things you can do around your house. So, getting loose rugs off the floor so you don't potentially trip when you go home, clean sheets on your bed, clean towels, so that when you get home, your home environment is clean as possible, which can help decrease your risk of getting infections.
Next question, when can I get back to driving my car?
So with driving the car, it depends on what hip you have replaced. So if you have your right hip replaced, because that is your foot you use for your gas and your brake, usually we tell people 4 weeks. On the left side, it can be much sooner. Usually I tell patients when you're off of a walker and then no longer requiring scheduled or around-the-clock narcotic pain medication. And for most patients, they can often get off of narcotic pain medications within a couple of days. So for the left hip, patients can often drive, sometimes 2 weeks after surgery, maybe 3 weeks.
The top right corner. See that? I don't know. Who makes a good candidate for this specific surgery?
So obviously anybody who has advanced hip arthritis, or there's other conditions, avascular necrosis, rheumatoid arthritis. So as long as you have the appropriate diagnosis, and then, like I said, pain at least for 3 months or longer, and then patients who have failed conservative treatment. Those are going to be patients who are considered appropriate for hip replacement surgery. And then as far as each individual patient, like I said, the more you can decrease your risk of having complications, the better. So controlling your medical comorbidities, stopping smoking, making sure you have dental care regularly, it can help prevent infections as well.
Will I have a visible scar and where will it be?
So depending on what type of surgery you have. So with the anterior approach, you have a scar that's roughly, I would say, 10 to 12 centimeters in length, and it will be on the front of your hip. With the anterior approach, some surgeons do a more vertical incision, and some surgeons do a more horizontal incision. The horizontal incision is called a bikini incision. Each surgeon has different incisions that they like for different reasons. I mostly do a vertical type incision unless a patient requests the bikini incision. The bikini, I've had patients who have had a bikini incision previously on on the other side and didn't feel like it was covered by their bikini at all. So they thought that the vertical incision actually was covered by their bikini a little bit more. So they actually have chosen to have a vertical incision. But those would be the two types of typical anterior approach incisions.
So Jeff Chansey looks like he has some questions and comments. Jeff, if you can type those into the chat, we'll go ahead and answer those questions for you.
One other question we have here is how much pain should I expect after surgery and how is it managed?
So, every patient's a little bit different. I would say in general, most people don't have a ton of pain after hip replacement. A lot of times the pain that they had before surgery is worse. For my patients, I would say most of them take a narcotic pain medication maybe for a few days and then typically can rely on Tylenol. So for my patients, I have everyone's going to be on scheduled Tylenol. So they usually take that every 6 hours. They'll also be on an anti-inflammatory, which we typically use a medicine called meloxicam or Mobic unless they have a contraindication for that. For a lot of patients, those two medicines can typically control their pain for the most part, and then they do have a narcotic pain medication like Norco or Vicodin that they can use when the pain's more severe. Other things that we do during surgery is we actually inject some medicines into the tissues around the joint. Those are numbing medicines and anti-inflammatories that will last for a couple of days that can help with pain in the early post-operative period. And so all that stuff, it's called multimodal pain management, and it really does control pain pretty well. As far as joint replacements go, whether you're talking hip, knee, shoulder, hip is by far the easiest recovery and has the least pain of all the joint replacements, at least for the majority of patients.
What type of implant or prosthesis will you use or do you use?
So there's certainly different brands. They all are very similar to each other. Most hip replacements done, there's a metal socket, which is made of titanium that has a plastic liner that snaps into it, which is called polyethylene. And then there'll be a femoral stem, which goes down inside your thigh bone that's made of titanium as well. And then usually that has either a metal ball, which is cobalt chrome, or most commonly a ceramic ball, which is similar to porcelain. And that'll typically form the new joint. Each surgeon often uses different brands depending on what they're comfortable with. I personally use a brand called Zimmer Biomet. Other brands are DePuy, Smith & Nephew, Stryker, and they're all very similar. And usually there's no difference in the long-term outcomes based upon the implant.
Thank you. Yes, we have a question in the chat. This is from Mr. Chansey. It says, I had a stem cell injection from an umbilical cord and it did not help. I'm 66 and play pickleball 5 days a week. My hip pain is getting worse. What are your thoughts on PRP versus hyaluronic injections versus total hip replacement?
So I would say if the stem cell injection didn't work, there's a decent chance further injections are not going to help as well. Depending on if you're without looking at your x-ray, I would say if you're bone on bone, it's pretty unlikely any of those injections are going to work. If your arthritis is more mild and moderate, then they can help. If I were going to choose an injection between gel and PRP, I would probably choose the PRP. In my experience, most of my experience with gel injections is in the knee, very less common in the hip. In the knee, it seems like it's 50-50 whether people get relief, and the people who get relief get very good relief, but the other people get really no relief. So, the only downside of doing another injection is if it doesn't work, you can't have surgery for 90 days. For a lot of people, that's not really a huge deal. They've lived with the pain for years, so another 90 days isn't that big of a deal. I would say if you have, decent arthritis, the injections really are buying you time. None of the injections are going to probably prevent you from getting a hip replacement, particularly at your age.
Can you explain a little bit more about OrthoGrid and the x-ray you use in the OR?
Yeah, so we use a C-arm, which is fluoroscopy, where I can take x-rays within the operating room. So the OrthoGrid it's a computer visual artificial intelligence. And so what it does is the artificial intelligence allows the computer to interpret the digital image or the x-ray. It's a static artificial intelligence, so it's learned everything it knows. It's not actively learning. So active artificial intelligence is what we mostly think of with artificial intelligence, where it's continuously learning. This has already learned everything it knows. To my knowledge, active artificial intelligence is not really utilized in medicine right now. And the OrthoGrid actually hooks directly up to the C-arm, and it'll take the C-arm image, and then it will use its artificial intelligence to identify landmarks within the x-ray. Some of those landmarks are visible to me, and then a lot of the landmarks are in the background. And I think it interprets about 30 to 35 different landmarks. And so what the OrthoGrid will do is it will help me in the positioning of the hip socket component. So you can orient a hip socket in different ways, and it'll actually give me degrees. We look at two things. One is called inclination, which is how vertical or flat the hip socket is. And then the other one is version, which is how forward facing or rear facing the socket is. And so the OrthoGrid will provide me both of those numbers, and I can move the hip socket to get it into the position I want it in. And then when I get to doing leg lengths and another variable, which is called offset. Offset is basically the relationship of your thigh bone to the middle of your body. And it's important to restore leg length and offset because they will restore the soft tissue tensions within your hip joint, which can help prevent dislocations. And so the OrthoGrid, what I do is I will take an x-ray of the patient's hip that's having surgery on it with temporary implants in place. This is done during the surgery. And then I will take an x-ray of the opposite hip, and the OrthoGrid overlays those two x-rays on top of each other. I can manipulate those images, and then I can use different landmarks on those images to help determine the patient's leg length and offset. And like I said, leg length is important because patients definitely can tell a difference if their legs are different lengths. It can cause them to walk with a limp. They may notice one of their pant legs is shorter than the other one. A few millimeters is not unusual, but you can sometimes see patients who maybe have a centimeter or more difference between their legs, and the OrthoGrid can help prevent those outliers. And then, like I said, just restoring the tension will help decrease the risk of dislocation.
Awesome, thank you. Well, I want to thank you, Dr. Stimac, for your time. I think we're going to try and wrap up here, but I do want to ask you if you could elaborate a little bit more on the unique approach that HSS at NCH has with having everything under one roof. So our imaging, our outpatient rehab, our surgery, our clinic, so on and so forth, and why that's important to both the patient and the surgeon.
Sure. So, this is a really unique hospital within the country, really, and it's a collaboration between two well-established healthcare systems. HSS being the #1 orthopedic hospital in the United States for 16 years in a row, really developed hip and knee replacements within the United States. So they are the elite of the elite institutions when it comes to orthopedics in our country. And with this collaboration, we've been able to really leverage all of their pre-existing protocols and bring them down to Southwest Florida. And so our goal here is to improve the orthopedic care within Southwest Florida. And by having everything within one building, it just helps us do that better. So we have physical therapy here in our building. The two leaders of our physical therapy came from HSS in New York. And they have a fantastic physical therapy staff, and physical therapy is so important after surgery. So I think that's really important that we as surgeons have a lot of comfort in our physical therapists, that they're the best around. And then, in the operating room, we know our staff. It's the same people every day, which is very important for decreasing complications, improving efficiencies. And then for a patient, it's really great to come to one place and be able to have everything done. You can see us in the office here. You can get your physical therapy here. You can get your imaging here, and you can have your surgery here. And that's very unique, really across the whole country. And I really think it's going to be a really great thing for Southwest Florida.
Wonderful. Well, thank you so much.
Thanks everyone for being on.
Yes, thank you everybody for joining us. We just noted in the chat, if you have any additional questions, you can contact us on the website. It's www.hss@nch.org. And thank you once again for your participation. Have a great day.